So good morning, everyone. I'm Chris. I'm one of the second year residents. So today I'm going to be doing a topic review on EENT, so ENT and ophthalmology. So just want to thank Dr. Gernsheimer and Dr. Hein for helping me put this together. So the first question, yeah, that's not going to work. Is that better? Okay. So the first question, a 45-year-old female, no past medical history, presents with right eye pain and redness for 1 day. She has photophobia and watery discharge from the right eye. She does not wear glasses or contact lenses, has no prior eye problems. On examination, the patient's visual acuity is 20/20 in the left and 20/70 in the right eye. She has conjunctival injection around the cornea and clear watery discharge. When fluorescein is applied, a branching white-colored epithelial defect is seen as pictured below. Which of the following is the most appropriate treatment for this patient? And I'll give a few seconds. Okay, so the answer is going to be D, topical antiviral medications. So this patient has corneal epithelial disease caused by HSV. So intravenous antibiotics won't really have a role in this disease. I'll talk about why B is not the correct answer for this patient. And the routine use of topical steroids is not recommended in HSV keratitis. So HSV and VZV can both cause eye involvement. It can range from conjunctivitis, scleritis, iritis, keratitis, and it can also include panophthalmitis. So our patient has HSV with eye involvement. The hallmark is branching or dendritic ulcers. And the treatment will typically consist of topical or oral antivirals. Both are acceptable, and the decision can be left up to patient preference. In terms of IV antivirals, it's usually reserved for immunocompromised patients with or without disseminated disease. And disseminated disease can be defined as multiple herpetic lesions in multiple areas of the skin. So herpes zoster ophthalmicus is caused by the varicella zoster virus when it reactivates, especially in the ophthalmic division of the trigeminal nerve. A classic sign of herpes zoster ophthalmicus is Hutchinson's sign, where you get a herpetic lesion on the patient's nose, as shown in this picture. So whenever you notice Hutchinson's sign on a patient, you want to make sure you examine the patient's eyes for herpes zoster ophthalmicus. And the treatment will consist of oral antivirals. You can do acyclovir, valacyclovir, famciclovir, but topical antivirals won't have a role in the treatment of herpes zoster ophthalmicus. And again, IV antivirals are usually reserved for immunocompromised patients with or without disseminated disease, or if there is sight-threatening disease. So question number 2, a 10-year-old girl presents to the ED for right eye pain and swelling. For the past 2 days, the patient has had cough, congestion, rhinorrhea for the last week. That is improving. On examination, she's febrile, mildly tachy to 115, respiratory rates 12, BP is 110/70. On eye examination, there's purple-red swelling of both upper and lower eyelids with injection of the conjunctiva. Pupils are equal and reactive to light. There's restricted lateral gaze, visual acuity is 20/70 in the right eye, and 20/25 in the left. And the rest of the examination is normal. What is the most appropriate next step in management? So I'll give a few seconds. So the answer is going to be C, administer vancomycin IV. So this patient has orbital cellulitis in the setting of a recent URI infection and sinusitis. So likely there was infectious spread from her sinuses. So A would be the right answer if there was anaphylaxis or histamine-related angioedema. B would be appropriate if it was pre-septal cellulitis. D can be performed if there's any uncertainty about the diagnosis, but you'd want to give vancomycin first, the antibiotics first. And E is incorrect. Okay, so orbital versus periorbital cellulitis. So our patient has orbital cellulitis, which is an infection deep to the orbital septum, which involves the fat and the muscles of the eyes. Typically, you'll have vision changes, pupil changes, or ophthalmoplegia. And treatment, it can be caused by usually spread from sinuses, but it can also be caused by like traumatic damage to the orbit, or infections from like the middle ear or the teeth. Treatment will usually consist of IV antibiotics, such as ceftriaxone, a combination of penicillin and napsilin or vancomycin. Staph aureus and H. flu are the most common etiologies. We also want to think about mucormycosis in those who are immunocompromised or in those who are diabetic. On the other hand, periorbital cellulitis is a superficial cellulitis that does not penetrate the orbital septum. So you'll have a swollen red eyelid, but typically you won't have any vision changes, pupil changes, or changes in eye motility, unlike in orbital cellulitis. And treatment will consist of Bactrim or Clinda with amoxicillin or cefidoxime or cefdinir. Third question. So a 19-year-old male presents to the emergency room after being assaulted. He complains of severe left eye pain after being kicked there. He complains of pain and decreased visual acuity in the left eye. Visual acuity is 20/20 in the right and 20/200 in the left. Intraocular pressures are normal in both eyes. Non-con CT of the facial bones is negative for fractures. Ultrasound shows an intact retina. Which of the following medications is the most appropriate management? So the correct answer is going to be C, homatropine. So this patient has a hyphema with normal intraocular pressures. A, B, and E can all be used to decrease aqueous humor production, which could be helpful if there was increased intraocular pressure, but not the case for our patient. And I'll talk about why D is not the correct answer. Okay, so our patient has hyphema, which is collection of blood in the anterior chamber. It can be due to traumatic causes or spontaneous causes, like in sickle cell patients. And the grading can help guide management and disposition. So you can consider outpatient follow-up if the hyphema fills less than 1/3 of the anterior chamber. But many will still admit these patients because 30% rebleed in 3 to 5 days. And these patients are at risk for elevated intraocular pressures. In terms of management, if there is elevated intraocular pressure, you can consider treatments like beta blockers and alpha agonists, such as the treatments you use in acute ankle closure glaucoma. Pilocarpine can also intraocular pressure, but it'll cause mydriasis because it's a cholinergic, and that can dilate the blood vessels and worsen the initial trauma. So if intraocular pressure is not an issue, you can use mydriatic agents such as homatropine, and this will help. So the pilocarpine will constrict the pupils. The homatropine will help dilate the pupils, and it's cycloplegic, and it'll help prevent the shearing of blood vessels caused by dilation and constriction of the pupil. You also want to elevate the head of the bed to 45 degrees and consider stopping antiplatelets or anticoagulants. And you want to make sure to consult ophthalmology as well. And this is a table showing the different gradings of hyphema. Next question, a 60-year-old man with a history of hypertension and migraine headaches presents at ED with a headache. He describes left-sided headache and eye pain that is associated with nausea and vomiting. On examination, his temperature is 97.6, heart rate 84, respiratory rate 12, and BP 134/80. His left eye is mid-dilated and non-reactive. His cornea is cloudy. Corrected visual acuity is 20/50 in the left and 20/20 in the right eye. Downal pen shows an intraocular pressure of 30 millimeters of mercury in the left eye. What is the most appropriate next step in management? So the correct answer is going to be C, timolol drops. So this patient has acute ankle closure glaucoma. Both A and B will cause constriction of the pupils, which can worsen the problem. Will cause dilation of the pupils because they're anticholinergics. And then tobramycin is an antibiotic. So C is the right answer. So acute ankle closure glaucoma is caused when there's blockage of aqueous humor output. Some classic presentations include headache, nausea, vomiting, eye pain, decreased visual acuity, especially in the setting of a sudden change in lighting. On examination, you usually see a fixed mid-dilated pupil with steamy cornea. Intraocular pressures will be greater than 20, but typically greater than 40 millimeters of mercury. And on slit lamp, you can appreciate an acute angle between the iris and the cornea, as shown in the picture here. Management will consist of keeping the patient in a well-lit room to help constrict the pupils. You want to elevate the head of the bed to 45 degrees. And you can decrease production of the aqueous humor by giving timolol, aproclonidine, an alpha-2 agonist, or acetazolamide. You can also increase drainage by giving pilocarpine topically, or you can decrease volume by giving mannitol. And you want to make sure you emergently consult ophthalmology. Next question, a 65-year-old male with history of diabetes, hypertension, coronary artery disease, and AFib presents with loss of vision in his left eye since he awoke 6 hours ago. The patient denies fever, eye pain, or eye discharge. On physical examination of the left eye, vision is limited to counting fingers. His pupil is 3 millimeters and reactive. Extraocular movements are intact. Slit lamp is normal. The dilated fundoscopic examination is shown below. Which of the following is the most likely diagnosis? So the correct answer is going to be B, central retinal artery occlusion. So all of these answer choices can cause sudden vision loss. But A, you'll have eye pain and photophobia. E, you'll usually have jaw pain or temporal headache. And fundoscopy can help differentiate between B, C, and D.
I think this question and picture is going to be on the boards, and you're in service almost every year.
Thanks, Dr. Silver. So non-traumatic acute vision loss can have differential can include many things, including damage to the vitreous, damage to the retina or the macula, or neurodegenerative diseases. In cases where there's damage to the vitreous humor, usually the debris will block the light, but the patient can still see. If there's damage to the retina, usually you'll have like a frank visual field deficit. But if it's like a sudden visual loss within like a few seconds, it's usually going to be like an ischemic cause. So central retinal artery occlusion and central retinal vein occlusion can both cause sudden painless monocular vision loss. And you can see Marcus gun pupils in both. And Marcus gun pupils are pretty much just a defect in the afferent pupillary light reflex of the affected eye. And it can indicate a lesion in the optic nerve or in the macula or the retina. And fundoscopy will usually help differentiate if there's a pathology within the retina or macula. So for central retinal artery occlusion, fundoscopy will show a cherry red spot with a pale fundus. Causes include emboli, thrombosis, hypoperfusion, vasculitis, and so on and so forth. Treatment, you can consider digital massage to help break up the occlusion. Breathing into the paper bag can supposedly cause vasodilation. If there's any concern for increased intraocular pressure, you want to treat that. And then you want to treat any underlying conditions. And patients will often have the same risk factors they have for other vascular diseases. And you want to make sure you emergently consult ophthalmology. On the other hand, central retinal vein occlusion, on fundoscopy, you'll see a blood and thunder appearance with scattered retinal hemorrhages, as seen in this picture here. And causes include thrombosis, hypoperfusion, and edema. And these patients you'll want to treat with aspirin, and you want to treat the underlying conditions and also get ophthalmology on board. All right, next question, a 7-year-old boy presents at emergency room after running into a branch while playing outside. On exam, he has intact visual acuity. Pupils are equal, round, and reactive to light and accommodation. Normal swinging flashlight exam. The patient reports pain around laceration as shown below and excessive tearing. Which of the following describes the most appropriate next step in management of this patient's injuries? So the correct answer is going to be C. Consult ophthalmology for laceration, exploration, and repair. So there are 4 main categories in which you would want to consult ophthalmology for lid-lac repair. The first one, as in our patient, is when it involves the canalicular system or the lacrimal duct system. You want to suspect this whenever you have a injury to the medial aspect of your eyelid. And you want to get ophthalmology on board to interrogate the integrity of the canalicular and lacrimal duct system. So they'll be the ones to repair it. The second is if there's a full thickness lid-lac with involvement of the tarsal plate. And the tarsal plate is the main integrity, and like it's an integral component of the eyelid, and it contains the meibomian glands, which are little glands that secrete the lipid layer of our tear film and helps prevent evaporation of our tears. So you want to get ophthalmology to evaluate that and repair it. If it involves the lid margin, you want like a more precise approximation of the laceration to prevent any lid notching. And if it involves the levator muscles, ophthalmology can repair that to prevent chronic ptosis. So now moving into ENT questions. A 19-year-old male presents with sore throat. He was seen in an emergency room 10 days ago for a sore throat and tested positive for strep pharyngitis. He was given a prescription for oral penicillin and discharged home. He initially felt better, but had worsening pain with adenophagia over the last day. Over the first day. On examination, he has a temperature of 101.5 pharyngeal erythema, right tonsillar pillar distension, uvula deviation to the left, and trismus. Which of the following is the most likely diagnosis? So the answer is going to be C, peritonsular abscess. So whenever you have a patient with persistent fevers, despite taking antibiotics or prolonged fever, you want to think about an underlying abscess. So peritonsular versus retropharyngeal abscess. Peritonsular abscesses will classically present with uvular deviation, an ipsilateral tonsillar pillar distension, ipsilateral talgia, and a muffled hot potato voice. Treatment is with IND and antibiotics. You can give amoxiclav or Clinda with or without steroids. And it's important to note that when you do the IND, the carotid artery courses 2 centimeters posterolateral to the abscess. Retropharyngeal abscesses are when an infection is in the deep neck space. It's commonly seen in children who present tripoding with hyoid tenderness. It can cause inflammatory torticollis, where the patient bends the neck towards the affected side, because when the patient tries to extend the neck on the affected side, it causes stretching of the prevertebral area. And on radiograph, it can show excess prevertebral swelling. And treatments will be OR drainage with IV antibiotics. Next question, you're working in an emergency department and are called by EMS for management guidance. They were on scene with a 5-year-old male who fell while hiking with his parents, avulsing his maxillary central incisor. The patient is otherwise well appearing, had no loss of consciousness, has no other injuries. The parents placed a tooth in a dry napkin, and EMS reports it is completely intact. Response time was 90 minutes, and they estimate it will take 2 hours to reach your ED. Which of the following instructions will you give to EMS? So the correct answer is going to be A, follow up with their dentist if the avulsed tooth is a primary tooth. So if it's a permanent tooth, then you would want to reimplant. But if it's a primary tooth, you never want to reimplant, which is why B and C are incorrect. D can be correct if it was a permanent tooth. And E, this patient is 5 years old, so there's risk for aspiration. So tooth avulsion, you only want to reimplant permanent tooth, which can erupt around 6 or 7 years old. So in the pediatric population, you want to make sure you distinguish between primary and permanent teeth. If there's any uncertainty, you can get some radiographic imaging to help decide. If it's a permanent tooth avulsion, you can manage it by, first you want to make sure you handle by the crown, which is the white part of the tooth. If it's dirty, you can clean gently under cold water for no more than 10 seconds. And then you can reposition the tooth back into the socket and then put it in place. You can have them bite down on like a soft piece of cloth. But if replantation is not an option, you can store it in an isotonic solution such as milk or saliva, or you can have the patient, if they're old enough and there's no risks for aspiration, you can have them just put the tooth in their cheek, inside their mouth. This can prolong the longevity of periodontal cells for up to 4 to 6 hours. But if the tooth has been dry for more than 1 hour, it's considered non-viable. And you'll have the most success of replantation if they also get root canal treatment within 7 to 14 days. So 55-year-old woman presents to the ED saying that her nose has been bleeding profusely for the last 3 hours. After 25 minutes of bilateral pressure on her nasal septum, there's still profuse bleeding. You place anterior nasal packing bilaterally, but bleeding persists. The patient's starting to get anxious. Vitals are without concern. Lab results show white blood cell count of 9,000, hematocrit of 34%, platelets of 225,000, and INR of 1.1. Under direct visualization, you note the bleeding originating from the posterior aspect of her septum. Which of the following is the most appropriate management? So this patient has posterior epistaxis. So you'll want to place posterior nasal packing, start antibiotics, and admit the patient to monitored hospital bed. B is not an appropriate management for posterior epistaxis, and most will not spontaneously resolve, I believe. C, there's no indication for transfusion. D, you want to admit the patient, and I'll get into why. And then E, silver nitrate has no role in posterior epistaxis. So management of episaxis, first you want to have the patient blow their nose to dislodge any clots. You can apply oxymetazoline, like Afrin, or phenylephrine nasal spray, but you want to be careful in those who are hypertensive. And then next, you can apply pressure to the cartilage of the nose, just distal to the nasal bone. But if bleeding continues and you suspect an anterior nosebleed, you can use chemical cauterization with silver nitrate. However, silver nitrate has no role in posterior episaxis. So if you identify posterior episaxis, or if the prior step fails, you can use nasal packing with sponges, balloons, or foams. And you can consider dipping the nasal tampon in TXA and applying it to the patient. Posterior episaxis should be admitted for OBS, and ENT should be consulted because these patients have a higher risk of bradydysarrhythmias and aspiration and rebleeds. And if the nasal packing is going to begin for more than 24 hours, patient will need urgent ENT follow-up. And you can give prophylactic antibiotics as well. And the last question, a previously healthy 35-year-old male presents with nasal pain after being punched in the face 6 hours ago. He denies headache and loss of consciousness. His neuro exam is normal. He's not on any other meds other than a swollen and tender nose. There's no facial swelling, bruising, or tenderness. His exam is below. Which of the following is the most appropriate course of action? So this patient has bilateral traumatic nasal septal hematoma. So you want to IND with close ENT follow-up. So septal hematoma, sorry, I'm gonna have to look at. So the septal cartilage receives blood supply from the perichondrium, and if there's a hematoma, it'll lift the perichondrium and cause septal necrosis. So undrained hematomas are a risk for necrosis and can serve as nidus for infection. To drain, you want to anesthetize the nasal mucosa by placing cotton plagettes. You can make a horizontal incision and avoid incising the cartilage. You want to remove the hematoma, and you want to insert bilateral anterior nasal packing coated in antibiotic ointment. And you can prescribe prophylactic antibiotics, amoxiclav 3 times daily. If the nasal packing will be in for greater than 24 hours, the patient should follow up with ENT. And make sure to check for nasal septal hematomas in all patients who present with facial trauma. And that was the end. Thank you.